Hi, I'm Anita Chary. I'm one of the incoming chief residents at the Harvard-affiliated emergency medicine residency, and today I'll be speaking with you about a resident-led health equity curriculum. To start out with some background, we know that resident physicians experience and encounter many types of discrimination in residency, and this includes discrimination that's directed towards patients or towards residents themselves. This can be related to race, gender, ability, sexual orientation. And this is a photograph of a busy day in one of our emergency departments at Massachusetts General Hospital. We know that during times of high stress, when we're working with limited information and working in time-pressured situations, the effects and experiences of discrimination can be amplified. So with this in mind, we decided to address these issues within our residency by creating a health equity curriculum. 4 of our emergency medicine residents who lead our social emergency medicine interest academy basically designed and implemented a curriculum over the academic year of 2019 to 2020. And we had 2 major goals. One was to raise awareness of race and gender-based inequalities in patient and resident experience. And the second goal was to build resident skills to address discrimination and to address microaggressions. We were mentored by 2 emergency medicine faculty members, Dr. Landry, who's one of our associate program directors, and Dr. Samuels-Callow, who is the faculty mentor of our social emergency medicine interest academy. Our resident team led 3 types of activities throughout the year as a part of this curriculum. The first was health equity rounds. The second was health equity retreat, and the third was a journal club, or 2 journal clubs rather, with health equity themes. So we'll talk about each of these in turn. To go through the first component of the curriculum, it was health equity rounds. And this was a lecture and panel-based series that introduced health equity topics and issues based in our own practice environment. This was incorporated into our residency's didactic curriculum, which residents are protected from clinical duties to attend. And the lectures have been given by Dr. Cleveland, by myself, and by guest speakers. And we also had panels with EM faculty and guest speakers about health equity issues. And these included things like the disproportionate impact of coronavirus on Latinx and African American patients in Boston. And the panels were moderated by residents, by Dr. Molina, and by myself. The second component of our curriculum was a health equity retreat. And this was a 3-hour session that was completely dedicated to health equity topics. Again, this was incorporated into our residency's didactic conference. So I gave a lecture about race as a social construct, and we used anonymous examples that EM residents submitted about their experiences of diversity in the hospital. Audience members then read those anonymous quotes aloud, and through audience participation, we discussed concepts like institutional racism, implicit bias, and privilege. Dr. Molina led a workshop about microaggressions, and microaggressions refer to indirect, subtle forms of discrimination against members of a marginalized group. And Dr. Molina led breakout sessions to teach residents strategies for responding to microaggressions. Dr. Cleveland, during our health equity retreat, led a case review and a panel about the role that race plays in decisions about whether to verbally or chemically de-escalate agitated patients, whether that's in the trauma bay or patients with mental illnesses. And based on the conversation of that last panel, Dr. Databoy created this algorithm and now leads a hospital working group that promotes unbiased de-escalation of agitated patients. The third component of our health equity curriculum was equity-themed journal clubs. Our residency hosts a monthly journal club, and this year, 2 of the journal club meetings focused on articles that were related to gender and race bias in residents' experiences. To understand the impact of our curriculum, we sent out anonymous electronic surveys to 58 residents and about 15 faculty members who participated in these sessions. And we received 29 responses. All of the people who responded to the survey said that the health equity curriculum helped improve their understanding of diversity in the workplace. And those who responded found that the most helpful activities were the interactive session introducing race as a social construct and the microaggressions workshop. Participants truly valued audience participation and the small group formats. And the major request that we got over and over again was a request for increased involvement of other stakeholders besides residents, and that included both faculty as well as nurses and other ED colleagues. As residents, we face two major challenges. The first of these relates to peer advising. With this health equity curriculum, we found that other residents were approaching this when they would encounter challenging issues related to diversity and racism. We felt good that we've created a safe space for people to have these conversations, but we don't always know the right answers or how to respond to what's raised. We have found it helpful to have various group chats for women and for people of color in our residency. The second major challenge we encountered was related to resources. So developing this curriculum required a lot of time, resources, and truly needed a diversity of perspectives. In our case, having clinical trainees with different social backgrounds collaborate is something that happened naturally, and it's something that really enriched our curriculum. But we think that further work is needed to figure out what are the appropriate ways to support residents who are doing this type of health equity work. Our next steps are going to include tailoring next year's series towards the topics that our respondents in the survey discussed as things that they would want to learn about. We also want to engage other groups in our residency in holding joint events. So we have a women's group and we also have a diversity and recruitment initiative. So we'll be teaming up to host joint events and collaborate. So in summary, resident physicians can take on leadership roles in teaching colleagues about diversity, equity, and inclusion. And these efforts have multiple benefits of not only promoting awareness of social justice from the ground up, but they also allow residents to develop leadership skills and form mentoring relationships. Thank you for listening, and please contact us with any questions.